Thanks, Hal. I'm going to do my usual slide blitz here because I'm not telling you anything you don't already know, and I'm going to just basically say I have a lot of questions about this, and I definitely have no answers, but I have a view on what the end game could be, I think, if we're lucky. So first, relevant conflicts. I feel like I always have to say this. I actually started as a comparative effectiveness researcher with a database. I became converted to God's gift of randomization as being critical, and now I've sort of come back to what I hope is a good middle ground, although it seems like everybody has a different set point for what the middle ground is. But after 35 years of working on it, I think it's obvious we need room in the big ecumenical tent for all religions. Just a framework of my thinking about this, and I think this is relevant to what I've had many conversations with Bob Temple about. I think it's important to define what area of research we're really talking about. I think on the issue of does a treatment work at all, that's where the experimental design has to be the starting point. Because if you don't know in the first place whether the treatment could possibly work under any circumstances, in my view, you're kind of lost. But how should it be used? In whom, for how long? That's what I think we're talking about today, and I think that brings up a whole set of other issues. And there I think the linchpin is the adequately powered inclusive clinical trial. About that, I mean what a lot of people would call a pragmatic trial. But all the pragmatic trials in the world you could possibly do can't possibly cover all the populations, and you all know that. So these are things I've heard along the way. The sort of Richard Peto teaching that I grew up with in the cardiovascular world would teach that in almost every circumstance, if you know the relative treatment effect and you know the underlying risk of the population from which your patient comes, that is a subgroup or combination of subgroups, the best estimate of what's likely to happen to that person is a combination of those two things rather than what you directly observed in that subgroup, because the subgroup's too small to get a reliable estimate. Now, in the end, I'm going to show you what I think a solution to that whole problem is, but you'll probably already think I'm crazy, but you'll think that even more when you see it. But having said all that, and it's illegal now in a big cardiovascular meeting to say anything but you can't pay any attention to subgroups. But what actually happens is everybody ends up looking at their data and then looking at the subgroups because they can't resist it, and you just can't possibly accept that the best answer is the average answer for the trial as a whole. So we're constantly battling our suppositions. And then if you throw out all the things that are patently obvious, and you've all seen this, but I think it's worth remembering that we're talking about most things are not patently obvious when it comes to medicine, then I think you really have to be careful. And we know there's a system that works. And I'm going to go quickly through this because I show it almost every time. I was tainted by the fact that I just happened to come into the real clinical world as a faculty member just when we discovered that blood clots cause heart attacks. And for some strange reason, it became fashionable all over the world to enter people into clinical trials the minute they hit the emergency department. Everybody seemed to do it, and it was easy to randomize tens of thousands of people into clinical trials and collate the data and get the answers. And when the answers were clear-cut, it was pretty easy to develop clinical practice guidelines, and then for whatever reason, it became fashionable to measure whether you were doing what the guidelines said as a standard of practice, and that happened all over North America at least. And what we ended up with in acute cardiac care was a measurement system for the entire population of people who at least made it to the emergency department alive. And what it allowed us to do was to discard 90% of what we tested fairly quickly and end up with only a few things that really work. And if we measured in these national systems whether people adhered to what worked, and did some fairly simple things with it, we could show that for every 10% improvement in adhering to what worked in randomized trials, there was an 11% decrease in mortality. And this is undeniably the entire population, because you can't run a hospital in North America without measuring these things as a routine. So that the argument now has become, should you even continue to measure it, because people are teaching to the test so well that the adherence measures are approaching 100%. Maybe people are too adherent and not paying attention to the exceptions. And I keep wondering, why doesn't this just happen in every field? And the sort of final thing for me was when the relatively skeptical Harlan Krumholtz published the paper that showed that, in fact, your risk of being dead in North America is about half of what it was when this whole thing started. So randomized trials with a measurement system that includes everybody, where the observations are done to identify whether it's working and then filling in the gaps, is a systematic approach to the whole thing that really ought to work. It also works in heart failure, chronic heart failure, that is, sort of annoyingly with almost the same relationship between adherence to guidelines and reduction in mortality. But then we have the case of erythropoietin, where you have dozens of shoddy observational studies fueled by companies making money and dialysis companies making money and doctors making money. And you end up with literally almost a dozen major claims about the wonders of high-dose erythropoietin, so that the guidelines now said in chronic kidney disease on dialysis, you must give high-dose erythropoietin, and if you do, you get paid more. The result was that the medical community was quite compliant, and look what happened to the hemoglobins of people on dialysis over time. And then finally, we were one of the first groups to do a randomized trial. It was a shocking thing for me. We got that call you hate to get on a Friday afternoon. You're killing people with your randomized trial with high-dose erythropoietin. This has been replicated time after time now, and so high-dose erythropoietin is a bad thing. When it was accepted dogma, it was a good thing based on dozens of mutually reinforcing observational studies. And so I sort of feel like unless we take a wholly systematic approach to this, we're going to have this sort of situation that you see in clinical practice every day. Now, the goal I think we'd all share is upper right-hand corner, both generalizable and valid at the same time. How do you get that? I don't know. But even in the acute coronary care trials that I talked about, where the application was measured in the whole population, when we looked at who was entered in the trials and who wasn't, there was a big gap, and in general, people entered into trials are younger and have a lot less comorbidity. That's true in every disease. I don't think there's any exception I've seen to that rule yet. Now, just to give you a specific example where I'm sure you guys in the panel are going to give me the answers to exactly what we should be thinking. Here's a trial that we were the North American Coordinating Center for. It was a global trial looking at a new P2Y12 inhibitor versus a standard clopidogrel. Exciting drug like they all are. And at the end of the trial, lo and behold, there was a reduction in major cardiac events and a reduction in total mortality worldwide. And in the standard blobogram that we all produce, Pito has been right almost all the time that when you do a blobogram, everything lines up on the same side as the average treatment effect. And more than half the time when it lines up on the other side, it was just a random variation. But the one thing that lined up on the wrong side here was being a patient in North America. And so we have a trial where in the rest of the world it appears to save your life compared to standard of care. But if you're in North America, it looks like it kills you. And fairly robust interaction here. Here are the outcomes. Bob Temple and the FDA had to grapple with this. They approved the drug, but with some kind of warning, may not work in the United States or something like that. And it turned out with a lot of sophisticated analysis, turns out North Americans get different doses of aspirin than everyone else. In observational analyses, that looked like it could explain it. It was good enough to get through the FDA. When I asked our own statisticians who did most of the analyses, they said, well, there's about a 51% chance that they're right and a 49% chance that it was just random variation and not due to the aspirin dose. And you've all seen this slide, which is something I think we have to stay constantly mindful of, that if you do a big enough trial and just look at horoscopes, you'll see differences in outcome due to birth signs. And this has been actually repeated in a number of trials now. The answer is this, I think, and we're getting dangerously close to it now. The new RFA from PCORI is a good benchmark in this effort. If we have a new data fabric where all Americans have electronic health records and all relevant patient advocacy groups and their related professional societies create quality registries with granular data, And then we have the third dimension, which is 300 million Americans, all with 1 to 5 cell phones apiece, recording biological data and sending in their patient-reported outcomes. We've got the whole population. And then we, as we're doing in our local environment in North Carolina, if you geospatially map people as to exactly where they are, you not only have the whole population, but by any characteristic you want, you can see exactly where people live. So these are actual individuals with diabetes in our case, where we have 98% of people with a common electronic health record. And so the endpoint for me would be you're not guessing about your sampling reference. You have all 320 million people. They're all in a data system. And when you do a trial, you know exactly who entered the trial and who didn't. And when you go to apply the therapy, you know what the outcomes were in the entire population to whom it was applied. Fairly simple end of the story and the way it's going to go. So we had a series of questions for the panel, and I won't go over these, but they're 2 slides long. I have no answers, but I have a lot of problems that I've shown you that I hope you have answers to. Thank you.